Well, thanks for joining us once again for something very similar but completely different. I've been trying to get this to happen for a very long time, so I'm as psyched as. I'm really, really pleased he's here. Thank you so much for joining us. Dr. Paul Mason will see us now.
G'day, Bart. Great to be here.
Yep, as I say, thank you very much for agreeing to do it. As I say, I've been chasing Paul for quite a bit. There's been a bit of tag. It's just never come together until now. As soon as we're all locked in our houses now, I guess it's the best time for us to do collaborations. So let's start with the obvious elephant in the room. Let's start with the topic du jour, I guess, for the last, few months really. This jolly pandemic, this COVID-19 disease caused by the virus called SARS-CoV-2.
Yeah, well, I mean, this has sort of got me quite interested because there's an elephant in the room and nobody's talking about it. So quite rightly, I think we're talking about how we make ourselves a smaller target. How do we reduce our risk of getting infected in the first place? And that's sort of social isolation, wash your hands, and we've all heard this ad nauseum. But nobody in the public domain, in the mainstream media, is actually talking about how we apply a suit of armor. How do we make ourselves more resilient if we actually get this thing? And this is just sort of madness to me because we're predicting that this is going to last for months and months and months. And based on the research that I've been doing, it looks like we can actually make very real changes to our lifestyles that will lead to a significant reduction in risk that would occur in a matter of weeks, days. So, and I'm just not sure why public health bodies aren't discussing this.
It's crazy, isn't it? Considering that the best likely estimates we are being given, if we can believe the estimates, suggest to us that we can expect an effective vaccine versus SARS-CoV-2. Never.
Well, I mean, God only knows when. I mean, I've been looking at some of the literature on vaccines and they've done some interesting stuff on the original MERS and SARS coronaviruses in animals. And they were doing a lot of work towards it in humans, but you know, once it sort of stopped being an issue, funding dried up and nothing was ever pushed through. And I mean, the fact is that if this vaccine comes through, it'll be the first effective vaccine in humans against a coronavirus ever.
Yeah.
Having said that, resources being thrown at it, I fully anticipate that we will end up with an effective vaccine. It's just that knowing when is crystal ball.
Exactly.
But if we have a look at, I mean, we know, 85% of people who get infected will get symptoms of a flu, or not even. There's a lot of cases of asymptomatic infections, people who have had the infection and they haven't even known it. But then there's this 15% of people who'll get a serious infection, usually characterized by pneumonia symptoms, where you end up with fluid and pus, literally pus in the lungs, and causes something called a cytokine storm and acute respiratory distress syndrome. And of those 15%, a portion will end up in ICU on ventilators, and even those on ventilators. And this is the whole thing people don't realize. If you go on a ventilator, you still only got a 4 in 10 chance of walking out of hospital alive. So the ventilator is not the solution that everybody is sort of making it out to be. Your odds are still less than a coin flip if you get it. So when we actually have a look, well, what separates these people, the 85% who don't get it seriously or don't even know they've had it, from these 15% who will get it more seriously? And when you actually have a look at the risk factors, we have hypertension, we have diabetes, we have heart disease, we have obesity. These are the things that are constantly cited as being major risk factors. And what do they have in common?
Chronic systemic inflammation, isn't it?
Insulin resistance. At a root cause, these people are insulin resistant. So basically what insulin resistance means is that your body responds less effectively to insulin. So it compensates by, if your pancreas is able, by increasing the amount of insulin you're producing. And we know this is strongly contributed to by diet, almost exclusively. So if you're having a lot of carbohydrates, if you're having a lot of seed oils, they're, basically processed foods. I mean, this is the signature of processed foods: seed oils and refined carbohydrates. They both contribute significantly to insulin resistance. And we know that insulin resistance, even before you actually have unstable blood sugars, will actually impair the immune system. And if we have a look at it, they did a beautiful study in Nature journal just last year. And it had a bit of an unwieldy title. It was called Longitudinal Multi-omics of Host Microbe Dynamics in Prediabetes. But what they did, they had two groups of people: insulin resistant, so metabolically unhealthy, but they had normal blood sugars. So they're like a bunch of the population running around with this early insulin resistant, what we call pre-diabetic, but they don't meet the criteria for diabetes. And then we had healthy people who didn't have this insulin resistance. And they assessed something like 41 different parameters in their blood repeatedly over a period of time. And throughout this period where they were being followed up, they often had viral respiratory tract infections. And when they measured these signaling pathways that are essential for the functioning of the immune system, so things like we call interferon signaling, Th1 pathway, IL-12, toll-like receptor signaling, there's 5 major ones that I could see in this study that were essential for a viral response, so for your immune system to protect yourself against a viral infection. And what we actually found that at the onset of an infection, the people who were healthy, who didn't have insulin resistance, they had much greater levels of activity in these pathways. And we almost saw it was just flat as a pancake. There was not much activity at all in the people who were insulin resistant. And in the words of the study's authors, this actually indicated that insulin resistance is effectively a state of immune suppression. And then we have another element of the immune response that actually is quite worrisome with coronavirus, and that's called the cytokine storm. So cytokines are these other tiny little proteins that signal from cell to cell, and they actually help. They call it, rally the troops, so to speak. They sort of bring in this immune cell, and they tell this to do that, and they cause inflammation, and so on and so forth.
I think of them as smoke signals from mountain to mountain.
Yeah.
Like.
So the cytokines are actually useful. But when you have what's called a cytokine storm, as we're seeing in coronavirus patients, it leads to uncontrolled inflammation, and that can actually be fatal. And it is proving to be fatal in a number of people. So we actually had a look at the cytokine levels within this study of people to infection. And we found that in the first 6 days, between days 1 to 6, the level of cytokine production was basically identical between the insulin resistant and the healthy individuals. But at 7 days, in the second week, we actually found that the people who were insulin resistant had a significantly higher level. And that by between weeks 3 and 5, basically the healthy population, their cytokine levels were totally back to normal. And the insulin resistant group still, even, 5 weeks after you have a cold, you should be better. They still had this significant prolonged elevation of these cytokines. So to me, this is very suggestive that this state of insulin resistance is causatively involved in, we know that all the pathophysiology, these conditions associated with insulin resistance seem to be associated with increased mortality. And this seems to be a mechanism that could potentially explain that. And I will point out again, it's insulin resistance without abnormal blood sugar levels. You don't have to be diabetic to have this effect. But if you are diabetic, well, everything's even worse, because then we know once you start having spikes in your blood sugar level, these sugars can actually attach to proteins and damage them. It's called glycation. And the problem is that when you glycate a protein, you defunction it. It doesn't function normally. And you can glycate something like a T cell, essential for the fighting a virus. You can glycate something like a natural killer cell, essential for fighting a virus. So if you then take it to another extreme, I've got elevated blood sugars and insulin resistance. Well, you're basically in an immune depressed state. Yep. You're not going to be healthy.
Yeah. So what do you think of the potential link, Paul, between the insulin resistance thing and, let's say, the thing that this virus generally is thought to be binding to, which is the angiotensin converting enzyme number 2 receptors. And
so we know, yeah, so this is true. So let's talk about how the virus actually gets into your body. So for most people, it's spread on droplets. So virus-laden droplets that get inhaled, and it will lodge in the throat. If you have a robust immune system at this stage, you can hopefully knock it on the head before it spreads. But if you don't have a robust immune system, and you've got these entry points for it to get into the cells, it can actually spread down the windpipe, the trachea, into the lungs and through the rest of the body. So that early robust immune response is actually, hopefully, these people, and it's actually quite telling that one of the first symptoms and one of the only symptoms that some people are reporting, the healthy population, is just a sore throat. It's obviously they're being infected and it's being contained in the throat. But the way it actually gets into the cell, it needs a little doorway, as you pointed out, and this is called angiotensin converting enzyme 2. And this is something that every doctor knows about. We get taught about this pathway in medical school called the renin-aldosterone angiotensin system, and so on and so forth. But what actually happens is there's certain states that lead to multiplication of this angiotensin converting enzyme 2. And it has been demonstrated that the diabetic state leads to an increase in their number. So there's all this hullabaloo about should you be taking these medications, angiotensin converting enzyme inhibitors or angiotensin receptor blockers and these things. And nobody was saying, guys, if you're metabolically unwell, this also increases the number. You should stop that. I've seen people ponder whether you should stop these medications. I've seen people specifically recommending, and I actually agree, that people who are smoking should get off the smokes. But I haven't seen anybody raise the fact that metabolic health is actually important in this. If you actually close some of the doorways for it to get into your cells, what it does, it makes the job of the immune system a lot easier. It means that that initial viral load that you have entering your cells is going to be much, much less. So the state of diabetes is it's a 1-2 punch. One, you're saying, here's the doorway, welcome into my cells, and let's just nobble half the immune system that's going to be responsible for clearing you guys out once you're actually in here. It's basically like an unwanted house guest.
Exactly.
And it's like opening your doors,
Yep. And then I've read a paper this week, Paul, suggesting that this particular virus is using a spike protein to gain direct access to T lymphocytes and debilitate them. Whoops.
Yeah, so this is interesting. We have a look at the white. So lymphocyte is a type of white blood cell. So we actually have 5 types of white blood cells. And neutrophils is the most common one, but they're traditionally thought to fight bacterial infections. And the most common one after that, and second most common, is what we call a leukocyte, a lymphocyte. Which is leukocyte means white blood cell, lymphocyte. And they tend to fight viral infections. And we're seeing, as part of this acute respiratory distress syndrome and this cytokine storm, one of the characteristic features is that we actually have a plummeting number of lymphocyte cells. We're seeing that on blood tests. And in actual fact, there's certain hematological parameters, things that we can see in the blood tests that will actually be quite predictive of if somebody's actually got a coronavirus infection. And a drop in lymphocytes certainly increases the probability that that's what's going on. It's not accurate enough for us to actually use as a diagnostic test, clearly, otherwise we would be. But it certainly does give us some insight into what's going on. So, this spike protein, if it's able to knock out these lymphocytes, you drop the numbers there, that's obviously correlating with a more serious infection. And the problem is you're taking away some of the cells which are designed to fight viral infections in the first place. This can't be a good thing.
Exactly. And then the other mechanism that I've been looking into was actually my dear partner, Pim, who alerted me to this line of inquiry. And it's the one that says that this particular virus is directly attacking the heme molecule and basically snipping the iron out of it and setting it free. And that's what's explaining the increased free ferritin levels in these acute patients. And so the suggested knock-on from there is that actually the respirator is contraindicated. What they need is oxygen.
Yeah, look, I've seen that paper. I have to be honest, I'm not convinced by it.
Okay, well, tell us why, because we need to understand this.
So, well, first of all, I mean, there are a couple of theoretical underpinnings. So we don't even know that the erythrocytes or the red blood cells actually have a express angiotensin converting enzyme too. That fundamental. So we sort of need biological plausibility.
Sure.
And we're looking at it, and I haven't seen any papers that actually demonstrate that this fundamental requirement for this theory to be true is in existence. And I'm happy to go off the railway and sort of accept, some quite, controversial theories, but as long as they're based in solid science. And for me, well, that would be a logical thing. And I actually have spoken to some microbiologists and some people in biochemistry. And apparently the genetic analysis tools, it's over my head, but the tools that they were using were actually a bit of a joke. They were actually not the gold standard tools for genetic analysis as was made out if you were reading the paper. And then if we have a look at this whole theory of free ferritin and things like this, well, the very mere presence of a cytokine storm and there's certain flavors of it, it can be associated with incredibly high ferritin levels. Anyway, this is something we know. High ferritin levels are associated with any inflammatory response. Ferritin is what we call an acute phase reactant. So this is what I'd call non-specific. Just because you have high ferritin levels, is it possible that some of the iron from heme could be contributing to that ferritin? Sure it is. Is it proof?
No.
No. And is it unique to this as a pathophysiology? It's
No.
Absolutely not unique. For me, this is not enough to sell me on that theory. And it's incredibly appealing. I mean, we want to think, okay, so this is a hematological issue. All we have to do is give people a blood transfusion and they'll be good. Because literally that's saying, well, if it's a problem that you don't have enough blood carrying oxygen around, then, the solution is very much easier there. I just don't think it's that simple.
Plus, of course, the risk of giving someone hyperbaric O2, you could be doing more damage to the tissue than...
Yeah, so I mean, the whole theory of hyperbaric O2 is treating it how we treat somebody with carbon monoxide poisoning, which is, the idea of carbon monoxide poisoning is that this it actually binds to the hemoglobin and displaces the oxygen. So if we put in a very high partial pressure of oxygen, that can actually then displace the carbon monoxide and trying to, avert that. But yeah, I would like to see some more work done on it. But certainly for my money at the moment, this is not one that I'm talking about. This is not one that I'm tweeting about. I think it could very well turn out to be nothing but a red herring.
Awesome. Okay, flattening the curve. We understand keeping presentations to acute medical care under capacity. We understand that's the driver. What are your thoughts on the many commentators saying, okay, sure, flatten the curve, that makes sense from that perspective, but actually that doesn't change the area under that curve, and that just prolongs the pain, destroys the economy, the death rate's real low anyway. What are people worried about, Paul? Why, I mean, this has not been done. This is unprecedented action, isn't it? Why now? Why this thing?
We've got the luxury of having this conversation now in hindsight. You're in New Zealand, yeah?
Yeah.
I'm in Australia. We are two countries that have hit it hard and hit it early, especially New Zealand.
Yep.
And what we're finding is that our hospitals are not overwhelmed. If anything, there's actually far less healthcare presentations. I know most doctors are actually not busy at the moment, which is quite interesting. So, and I think that's just because we've got the luxury of having had governments that have actually taken potent, credible action. So now we've got the time we can reflect on it. If we hadn't have taken that action, we could have, realistically been in Italy or in New York or something like that. And dare I say a Wuhan, because I think the true story of what happened in Wuhan, you don't go and build a 1,000-bed hospital in a week. if there's, based on the official figures that the Chinese government was releasing at the time. That just seemed total overkill. So clearly there was more severity to that going on then. But now we're in the situation where, in Australia, for instance, we're actually now having the discussion about, do we reopen elective surgery? Do we allow, people who need an ACL reconstruction or something, maybe something a bit more evidence-based, but, need a surgery, do we allow those guys to actually get their surgery? So, and that is a conversation that I honestly didn't think we would be having at this point in time. We've now got enough protective equipment that we can protect a lot of our doctors if we're in surgery, and we're not at risk of depleting a very restricted stockpile. The rate of community transmission is very, very low, such that it's very unlikely that any individual patient would actually have the condition. We're able to protect ourselves as healthcare workers quite well. I mean, GPs are probably at the highest risk because they don't know who's got it when they're coming in through the door, and they see a lot of people. But people in ICU, hopefully, doctors in ICU, nurses in ICU, they're hopefully able to wear appropriate PPE. So I think it's reasonable to now be having this conversation we're now having of, well, what is too far? If we destroy the economy, destroy people's livelihoods, we saw a spate of suicides in the global financial crisis. We've seen that in every major economic downturn in most countries around the world. We know there is actually a real world impact of destroying the economy as well. And that has flow-on effects. You can't just flick a switch. It takes years for the economy. Even if we turn this off tomorrow, it still would take years for the economy to reboot to what it was pre-coronavirus. And I mean, I don't profess to be an expert in epidemiology. I'm certainly not an economist, and I don't know where that balance falls. But I certainly share your concerns that at the moment, if we are pursuing this strategy of suppression, the only end game is effectively going to be a vaccine. And if that comes out much sooner than we thought, well, we'll pat ourselves on the back and say we did the right thing. But if it turns out to be 18 months or longer away, then as you said, we've prolonged the pain and we still don't have an exit strategy.
Yeah, so, and therefore we've saved nobody. Actually, the number of deaths will be the same. They'll just be spread out. And the economy will be destroyed as well. Because, I mean, my theory, I don't know how you feel about this one, Paul, but my theory on viruses is that you can't hide from them. You can't prevent transmission. The whole point is that enough of a population has to be exposed so that there is enough distance physically between uninfected people that's why the incidence comes down and down and down over time as the herd immunity builds up. But there is no way to avoid that process except by exposing people or giving them the vaccine. Now, given that we do not have a vaccine or any likely probability of a vaccine, if you're listening to the people who are actually charged with producing it, then that's why I'm asking the question. Let's go with the facts of what we know. So whatever the end goal is, it's going to be effectively herd immunity. So the idea is we want enough people to be immune to the effects of it so that it can't spread from person to person. If I have the disease and I'm surrounded by 5 people and they're all immune, then it doesn't matter whether I have it or not. And the numbers, the estimated number is, about 70%. About 7 in 10 people need to be protected to suppress what we call the reproduction value, or the R0, low enough so that this will cease to be an issue. Now, the question is, so we're finding that 15% of people are at risk, or are having, significant problems. Wouldn't it be wonderful if we could identify which group you're in, if you're in the 15% or if you're in the 85%? Because then it would be easy. Then we'd just say, you're not allowed out. Or if you do go out, you do it at your own risk. And everybody else... Are you actually heretically suggesting that we quarantine the people who are at risk instead of everybody? Well, here's the problem. We don't have a good understanding of who is at risk. And when I say we, I think that we do. I personally believe that insulin resistance is. And what I would
think would be interesting is what would happen if we gave everybody a fasting insulin test and we had a look at their inflammatory markers, and these other markers had a look at their triglyceride levels and their HDL, these markers that we know correlate extremely well with insulin resistance. And let's do a small scale study, maybe 5,000 people, and actually see when they get infected, what happens. If that turns out that that is a reliable predictor of who dies and who doesn't die from coronavirus, and we can, as you know, with reference ranges, we can draw the line anywhere we need. We can be ultra conservative or a little bit more gung-ho. So we could draw the line somewhere to say that, if you get infected with this parameter, you've got a 99.9% chance of surviving. I think most people would accept that. I've got a 1 in 10,000 chance. Okay, I'll take that. That's good. And then what proportion of the population would be in that group? And if that was 70%, then you're set, right? Because then you say, well, we'll release that. We can open the doors to that 70%. It's almost along the lines of what we call in athletics a biological passport, but it's a little bit different. It's a hematological passport. If your blood markers you meet these certain criteria, you can, you now have permission to go and expose yourself to it and get it, because we know that you're probably not going to clog up our emergency department. You're probably not going to clog up our ICUs. But one thing nobody's talking about is if we did that, I don't think we'd get to 70% of people who would actually be in that incredibly low risk. And we know this because when we had a study from the American population, only 12% of American adults were metabolically healthy in all 5 metrics of metabolic syndrome. And only 2% of those people who are over age 65 were. So, we're surely going to struggle to actually have people with that. But we know that in short order, we can actually put people in that category. I have patients who I follow, and just in the space of 2 to 4 weeks, I can get wholesale changes in their blood markers and their metabolic risk markers, just with dietary change in a matter of weeks. And we know that, if you're worried about elevated blood sugar levels, I can literally drop your blood sugar level overnight just by changing your diet. By not putting crap food in, we can literally transform your risk. And it's not that you'll get the full magnitude of benefit overnight, but you'd get a pretty big improvement. And over the next couple of weeks, it usually takes about 2 weeks for somebody starting a strict ketogenic diet for us to see that their blood sugar levels will stabilize down at a level that I'm happy with. So if you think about it, we could just wholesale give people good dietary advice, good exercise advice, good advice on sleep. These other things that we always muck around the edges, but they're bloody important. We could get that 70% population that we say, guys, go and infect yourselves.
Yeah. And that would probably be a quicker change that we actually could make than what is going to be required to produce this vaccine, I can promise you, boys and girls. So I think that's a great approach. Of course, everybody knows on this channel that I don't give nutritional advice per se, but I am quite clear about my humble opinion about what the optimal diet for human beings is. And it is one that is very, very low in carbohydrates. You don't disagree, do you, Paul? Of course.
I'm a fan of low carb diets. And but the corollary of a low carb diet is it's a high fat diet. And we have a bunch of people scared about cholesterol.
Yep. I'm not one of those.
Thank God for that. So here's the thing, because you know what the association between high cholesterol levels and dying from infection is?
I wouldn't know that one particularly.
Way down. So we know in one study, they looked at a group of men. If your cholesterol was under 70, your LDL cholesterol was under 70 versus over 70, your risk of dying from sepsis related to the pneumonia was increased in the low cholesterol group by 5 times. We know all-cause mortality. We know that, if we have a look at the balance of data, big meta-analysis looking at 19 studies, 16 of those studies found an inverse relationship. It doesn't matter whichever way we look at it. When we have a look at total cholesterol, we have a look at LDL, we have a look at HDL, there appears to be an inverse relationship between all-cause mortality and mortality from infectious causes in all of those. So right about now, if you were truly worried about dying from an infectious disease, now's not the time to be lowering your cholesterol.
No.
Now's the time to be going on a diet that might actually increase it.
And especially not with a drug, which is a metabolic toxin, a mitochondrial toxin that will lower your redox potential and thus lower the ability for you to undertake respiratory burst and thus protect yourself from pathogens.
Not many people know about the origin of the statin medication, the HMG-CoA reductase inhibitors. So I don't know if you're familiar with the original research.
Quite, yeah. But please, Paul, go.
Yeah, I mean, well, it was being, the Japanese scientists were the first to discover the statin medications. And they ended up in a bit of a quasi-war, a battle, a race with the American scientists. And the Japanese are actually progressing very well. And then they pulled out of the race. The reason they pulled out of the race, too many of their lab animals were dying. So they were dying from cancer, dying from other causes. And they just decided this is not safe. And probably the truth is that they were probably dealing with very potent statins that did what they were meant to do very, very well. They really blocked this HMG-CoA reductase. So the only way that the Americans were able to get FDA approval was by bypassing the normal channels. They had approval in record time with, incredibly little oversight and no real scrutiny of the side effects that they were causing. But then, interestingly, I think it was Bayer, they came out in the 90s with what they called a super statin. And that was, they wanted a piece of this statin pie. These are billion-dollar drugs. So they put out this super statin that was more potent at lowering people's LDL level than ever. And you don't hear about this super statin anymore. You know why?
Because it killed people.
Killed too many people. Yeah. Exactly. And you know what? They've actually, should be in the public domain. They actually had to pay out, I believe, in the order of over $100 million or more in compensation. So people knew that this drug was dangerous. And the only difference between this drug and the drugs that we have on the market is one of potency. So basically it was so much more effective. So one would wonder if you took a current statin in a high enough dose, would that render it as equally effective as this super statin was? Potentially, yes.
I think it would kill you at high enough level.
If you inhibit HMG-CoA reductase enough, it is essential for life. We do know that. The Japanese scientists figured that out. They've got a lot of dead dogs on their doorsteps that will tell you that.
Interesting, isn't it? So from there, Paul, time does march on. So let's move on if you don't mind. As soon as I've got you, it's obligatory. It's Dr. Paul Mason. We have to talk about fiber for a few minutes. We all know the story on this channel because I've drummed it into my people from day one. And that is that, to my knowledge, there is one and only one controlled clinical study regarding fiber at all. Is that still correct, Paul? Or?
Well, look, there are lots of studies, but the outcome measures that they look at, it doesn't reflect what I consider the symptoms of constipation. So if I'm as a doctor, if I have somebody come into me, I'll say, with a gastrointestinal upset, they'll say, look, I have pain, I have bloating, I have bleeding. They don't say, my stool isn't big enough. Literally, nobody has ever said that to me. They don't say, my transit time is too slow. Nobody even knows what their transit time is anyway. And yet, the studies that have actually been purported to prove the benefits of fiber will usually look at stool bulk, and they say, fiber makes your stool bigger, fantastic. Or they'll show transit time. Why? Because we know that fiber, because it's insoluble, does make your poop bigger. But let's be honest, making something bigger doesn't make it any easier to pass through a small hole. So, I don't understand how that logically makes sense. And while it might speed transit time through an irritative function, that doesn't necessarily help either. I mean, that nobody's ever complained about transit time. So if we have a look at the symptoms, the only one study that I could come across, I was writing a textbook chapter, a medical textbook, and I was up to the fiber section, and I was going through the science in every topic, and then I came to fibre, and I had a hell of a lot of trouble finding the original references. I could go guideline after guideline after guideline. So this original guideline would cite another guideline. It would cite an opinion piece. It would, and there was no original data. There was no experimental data saying what they said it was. And I finally came across this study where they had 63 people. And they were, it wasn't a true randomized control trial, but it was an experimental design. And they had idiopathic constipation. Idiopathic being a term we use, your doctor's an idiot and probably pathetic as well. Idiopathic in the technical sense means we don't know what causes it. So for most people with constipation, it is idiopathic constipation. That's just a term saying garden variety constipation. They were on a relatively high fibre diet, but then they put some of them on an even higher fibre diet, and their symptoms got worse. These 5 symptoms of constipation, like bleeding and bloating and pain, so on and so forth, they all got worse. Then they had some people on a medium fibre diet, got a little bit better, low fibre diet, got a little bit better. And then they had an elimination diet, 0 fibre, 41 participants. And every single one of these participants who had symptoms of constipation had complete resolution in every single metric of their symptoms, these 5 domains, every single one. And the average rate of bowel motions was 1 bowel motion per day, every day. The high fibre group had 1 bowel motion from memory every 6.83 days. So no comparison, absolutely no comparison. Basically 1 poop a week on a high fibre diet. And these were obviously people who had struggled with constipation for a long period of time. And then people say, oh, but you need fibre because it produces short-chain fatty acids. Well, yes, it does. So what actually happens is that you'll have bacterial fermentation of the fibre because your body can't absorb it because it's basically a waste product, right? It's like eating wood. So these bacteria will ferment it. They'll produce gas, which is why you feel bloated. And then they'll produce short-chain fatty acids, which can get absorbed into some of the cells lining the intestines. And then the cells lining the intestines will convert that into ketones. And then they'll use the ketone as a source of energy, and that will make that cell healthier and stronger, better at producing mucus to protect itself, so on and so forth. But the problem is, this bacterial fermentation only occurs in a very focal part of the whole intestine. So there's only a very, very small number of these cells that will benefit. Far better for you to be in systemic ketosis and have ketones circulating around your whole system and being able to provide you with that thrust, with that energy and that entire gastrointestinal tract protection. So this whole short-chain fatty acid argument doesn't stack up either. And then we have these talks about, oh, you have to feed the microbiome. Bollocks. I mean, the microbiome is the biggest case of misunderstanding of correlation and causation I've seen in recent times. So we all know that, oh, you know, just because the sun comes up, you know, doesn't mean that this happens. The sun coming up doesn't make your alarm go off, even though they tend to happen at the same time. That's just, you know, they're correlated. One doesn't cause the other. So when we have a look at the data, so we take a population of epileptics who are on a ketogenic diet, and we look at their microbiome. They have a phyla, the Bacteroidetes phyla predominance, and this is associated with good health. And yet, we don't say that this Bacteroidetes phyla gave these epileptics better control against their epilepsy. We say because they fed their bacteria different things, they fed a ketogenic diet. It was actually the ketogenic diet that protected them from epilepsy relatively. And the ketogenic diet just happened to change their microbiome, because we know we can get wholesale changes in the microbiome in a matter of 24 hours. If you feed it certain foods, certain bacteria that like those foods will outcompete some of the other ones, and they'll suppress the other ones. So 24 hours, big change in your microbiome. So correlation, causation. And we know this. Let's take the example of trehalose, which is a sugar, a disaccharide. It's synthetically synthesized. The Japanese discovered how to do it on an mass industrial scale in the early 2000s. And it's fantastic because it lowers the freezing point of foods. So it's really good for industrial food manufacturers to put in things like ice cream. So I think it was about 2002, 2003 in Australia, this got introduced into our food supply. Now, there's a bacteria in our gut called Clostridium difficile, which causes a dangerous condition called pseudomembranous colitis, where we get absolute massive inflammation and bloating, and it's incredibly dangerous. It does kill people. And this bug that causes it, Clostridium difficile, has an affinity to ferment this sugar, trehalose. So we noticed this epidemic of pseudomembranous colitis starting at this point in time when this got introduced into our food supply. And other countries around the world have also noticed the same thing. When they've had the introduction of this into the food supply, they have epidemics of this condition. And this is not just sort of some, bespoke theory that I've come up with. I've taken this from Nature. This is well published. There's a couple of articles in Nature Journal on this. This is solid science. So what you feed your bacteria will actually, what you eat will determine which bacteria are proliferate. And for the most part, there might be some small around the edges effects, but what you eat in the first place is a much more important impact on your health than what the bacteria subsequently do. And we know that if you feed people lots of probiotics, that often causes gastrointestinal upset. And if you eat a bacteria through a probiotic that you then subsequently do not feed, it will basically die off. So you'll need to be continuously having that same probiotic if you actually want to maintain that population, or you can just change your diet to feed a healthy bacterial population. The only way probiotics work, say if we want to stop you getting a bad strain of E. coli for causing traveler's diarrhea or something like that, is if you continuously ingest that probiotic in high doses. Then it leads to a relative degree of competition where it can hopefully stop that pathogenic E. coli from getting a foothold in your microbiota. But as soon as you stop taking it, it's gone from your system. And there's a very good paper in India. There's a condition called necrotizing enterocolitis, which is often preterm infants often suffer from it. It's quite dangerous. And they have an overgrowth of very bad bacteria in their gut. And they found that they gave them a probiotic that would actually help compete against this infection. And it did nothing because they didn't nourish that bacteria. So then they coined the term symbiotic, synergy, where they actually gave it a source of food at the same time as giving the probiotic. They basically attached them together. And that proved to be very, very effective. So it really just goes to show that what happens in our gut is more of a reflection of what we eat, and what we eat impacts our health at the same time impacting our microbiome. And I really think a lot of the stuff coming out about the microbiome at the moment is nothing but junk science.
Yeah, agreed. Absolutely. I think that there is some stuff whereby, there are people, including myself, that often say we know more about the surface of Mars than we do about the microbiome in real terms. And I'm sticking to that until I'm proven wrong on it, which will happen at some point when the knowledge develops on it. But certainly we are clear that there are certain things that are associated quite often with patients who present with inflammation. So we know there are certain diets that are pro-inflammatory at large, and certain diets that at large are anti-inflammatory.
Yeah.
We know that inflammation is at the root cause of insulin resistance. We know that insulin resistance is the underpinning of type 2 diabetes, obesity, many cancers, many dementias, many comorbidities of the exact population of people who are smack in the sites for this SARS-CoV-2 virus. And we know that we can ameliorate fairly quickly in terms of someone's metabolic function just by altering their diet. And what we're finding is the most effective method, as far as we can tell, is to remove pretty much all the carbohydrates and fiber and oils. Yeah,
exactly. I mean, what I've talked about so far, I mentioned the Bacteroidetes phyla being a good one. Well, the one that is not a good one is Firmicutes. And this one feeds on processed carbs. If you have an unhealthy diet, you are going to get this population thriving in your microbiota. That doesn't mean the Firmicutes is doing the damage to you, though. It's the crap diet that's doing it. The Firmicutes is just coming along for the ride.
Exactly. And it's therefore implicated as being a bad guy in the same way that cholesterol is implicated in heart disease, which is fundamentally ridiculous from the ground up. Analogy, firemen at forest fires. They didn't cause the fire, but you'll always find them there. They're not the cause. Cause and effect, again, isn't it, Paul Mason? It's the same thing. It's these people who want to run around and pretend to be knowledgeable, touting associations as causal artifacts. When does it end, do you think?
Well, here's the problem. We've had the wool pulled over our eyes for so long now. I mean, my very medical education was an exercise in misinformation for a lot of it, certainly as far as nutrition went. So, and this goes back a bloody long way. We go back to the famous Sydney Diet Heart Study, which was done in the late 60s, early 70s in Australia. And, this was done on men who actually had a history of coronary disease between 66 and 73. So basically they got men who had had heart attacks and they said, okay, you have your normal diet rich in saturated fat and you have your diet rich in polyunsaturated fats. Well, the results weren't ever fully published. They just weren't published. It was finished. The data collection, all that was done in 1973. And the true results were only published in 2013, some 40 years later.
Wow.
Why? I mean, God knows why. And how did they actually get published? Well, some guy, a guy called Chris Ramsden, actually discovered them on 9-track magnetic tapes in somebody's basement and basically, had to get permission to publish them and interpret them and, had to get IT help to, basically go back to this 40-year-old technology. And what did they find? Well, they found that those guys who were in the polyunsaturated group were 62% more likely to die. Say that again, 62% more likely to die if you have the oils and fats that are recommended by dietary guidelines. And then we had this, what's called the Minnesota Coronary Survey that was run between 1968 and 1973. This was over 9,000 men and women in institutions. So they knew exactly what they ate. They knew exactly what they were doing and records were meticulous. So 9,000 of these guys, it was double blinded. And they basically looked at a high saturated fat diet and a high polyunsaturated fat diet. And the data collection finished in 1973. And then it took 16 years to publish the data. So why? Why the delay? Well, when the lead investigator was still alive, they asked him and he said, well, it's because our results were disappointing. We didn't get the results we wanted. We had a hypothesis we wanted to support, clearly didn't support the hypothesis, so we thought would fudge it. And it would be interesting to you note that one of the co-investigators on this study, Ansel Keys.
Yeah.
Although his name wasn't on the paper when it was published. And even when they published it 16 years late, they still left off a lot of vital information. And that information only was again published in 2016. And what did this data that they didn't report on initially find, over 40 years later? Well, when you replace saturated fat with vegetable oil, your cholesterol does go down, correct? But you also are much more likely to die. So again, the same finding. So when you're saying, where does it end, this whole correlation causation, I don't know that it's people genuinely misunderstanding correlation causation, or are they deliberately trying to deceive us because they've got a preconceived notion, they've got a personal agenda that they're trying to hide. And we move to the modern era, the Women's Health Initiative study that was published in 2006. So it was over 48,000 females who were either in a low-fat diet or not a low-fat diet. So for $700,000, you buy yourself a bloody good study. You don't leave anything to chance. You have big numbers, properly randomized, properly supervised, and then you would assume that when it comes to writing up the manuscript, that would be incredibly well edited. You would have, editors coming out. So the funny thing is, I don't think they got very good value for money because there was only one statistically significant finding in this whole goddamn trial, and they forgot to put it in the results table. Awesome. They forgot to mention it in the conclusion. They forgot to mention it in any of the press releases. They forgot to mention it in any of the multiple media interviews. I think they actually, they were ripped off as far as their editorial support. $700 million doesn't get you a lot these days. But what that finding was that if you're a female, there's a Women's Health Initiative, and you had a history of heart disease and you went on a low-fat diet, you were 26% more likely to suffer side effects like heart attacks. Read low-fat diet, 26% more likely to have a heart attack. That was the only statistically significant finding from the whole study. So that finding should have been shouted from the rooftops. And essentially it was buried. You could only find this out in page 661 of the journal, buried in obscure text with no elaboration at all. And it's quite immune to any penetration by anybody but the most inquiring minds who say, hang on, what does this incredibly obscure sentence mean? So from memory, it was something along the lines of the HR for those in the low fat group was 1.26. And what does that even mean? So, you know, have to say, well, HR is hazard ratio. We presume they're talking about, you know, cardiovascular events being like heart attacks. And there's a degree of where you actually have to interpret that. And funnily enough, even though they said this was, they didn't say it was the only statistically significant finding, but when you have a look at the confidence interval, it's very obvious that it was. Why was that dropped off the results table? Why was it dropped off the conclusion? You know,
because it wasn't in line with the ideology they were pushing.
I think there is a degree of deliberate deception. And I don't say that lightly. I've only recently started saying that. But when we have a look at this, there is a clear pattern of these investigators who are pushing a barrows, you know, trying to provide their own agenda to support their own narrative, that narrative being the lipid heart hypothesis. And unfortunately, they're being incredibly disingenuous and they're deceiving the public by way of omission of information.
Yep.
And so when you say, where does it go? Where do these misunderstandings end? Well, I think it's when we call people out and we call academic dishonesty what it actually is.
Oh, thank goodness, my life has purpose. Oh, yay. I've repeatedly done just that on my channel, Paul. It's all about calling the charlatans out. So I'm really, really glad that that's all come out and that I'm not the only person saying it. So thank you for that.
Look, not all, I will make a point though, and maybe I'm getting a bit defensive because I'm a doctor. I don't think doctors by and large are evil people. But if you've been through medical school and you've studied for X number of years and you've had this stuff rammed down your throat, I think it's difficult to actually comprehend that what you got taught was actually not just wrong because it was, you know, through quirks of research at the time, but through deliberate deception. That is very hard to take. And I don't think most doctors deliberately go out to give their patients bad advice. I know most doctors don't do this. Most doctors genuinely want to help their patients. So as you know, as silly as this sounds, I think doctors are victims as much as the general public in this whole era of misinformation.
Yeah, absolutely agreed. Paul, how are you for time?
Look, we can go on for another 10, 15 minutes.
Brilliant. Okay, so I had one more thing I wanted to talk to you about it at this time, if we could, and that's just to briefly cover again the whole idea that we're being told, and that is that you cannot perform at a high level as a high-level athlete if you do not consume carbohydrates in your diet. Now, I've already covered this, of course, on my channel, and my people that are already subbed will know the story, but hopefully, you know, you being here will drag more people to the channel. And so give it to us again. Well,
I mean, that's just patently absurd. A lot of the research, I actually did presented at a conference, a back-to-back session with Louise Burke, the queen of high-carb diets, at the College of Sports Medicine conference earlier this year. And we did back-to-back presentations, and essentially it was set up as a bit of a competitive forum there. And I had a look at her paper, the Supernova paper, in detail. And the only conclusion I can come to it is it's fundamentally flawed. It's got so many methodological errors that it really doesn't stack up at all. So let's go back and say, well, why do we recommend high-carb diets? So in the 1960s, they developed the percutaneous needle biopsy where we could stick a needle into a muscle and go, oh, we measure stuff. Here's glycogen. And that was the tool that the scientists at the time had. And they were able to find that when glycogen stores were depleted, people were fatigued. Fair enough. And then they found that, well, glycogen's made up of glucose molecules. Carbohydrates are made up of glucose molecules. So there again, we have this theory that wasn't ever empirically validated. So they said, well, so all we need to do is feed people more carbohydrates, they'll have higher glycogen levels and so on and so forth. So people who were on high carbohydrate diets, they actually did some studies and they found that for those people on high carb diets, they actually did better and so on and so forth. And that was actually, what they believed. And then Louise Burke, she was in charge of a team. They did this fantastic, pretty logistically complex study actually. And they got elite world level race walkers from around the world, and they actually put them on a low carb diet for about 3 weeks, and then they assessed their performance. And basically they said, oh, it impairs their performance. But there's a couple of fundamental flaws. Number one, they assumed that rate of fat oxidation equated to keto adaptation. So just because you can burn fat to produce ketones doesn't mean you can efficiently use ketones. And we have damn good evidence for this. There have been studies that show that you probably need at least 6 weeks to actually efficiently use the ketones. So cellular machinery to use the ketones requires upregulation over time. And I actually use a surrogate marker for this in my clinic called uric acid. Yep. So if I have an athlete who starts a ketogenic diet, I monitor their uric acid, because if they're not able to effectively use their ketones, the body has to get rid of them in the urine. And it then competes with uric acid for excretion, because that's also excreted in the urine. There's only so much that you can excrete. And if you lose more ketones in the urine, you force the body to retain uric acid. So we can actually see an elevated uric acid level in people who aren't fully keto adapted when they're on a ketogenic diet. And that can take weeks for that to fall. And in actual fact, it can take months. There's been some studies that show that it takes at least, even at 12 weeks after starting a ketogenic diet.
Really? I've seen 20 weeks, Paul.
Uric acid levels are still falling. And anecdotally, most athletes report they don't fully hit their stride until 4 to 6 months after commencing a ketogenic diet. So this was basically, they were looking at athletes that were incompletely keto adapted in this study. Number two, these athletes were not aggressively, they basically weren't supplemented with sodium. And we know that on a ketogenic diet, you lose sodium because the drop in insulin means that you have these 4 transporters in the kidneys that will actually leak sodium. And as Steve Finney found in some of his early studies on physical performance, unless you aggressively and specifically supplement with sodium, your performance will be declined. They're also deficient in other electrolytes like potassium. And potassium is actually needed to build muscle. A lot of people don't actually realize. So a little bit of a diversion here, but in one study, it was the type of study that we could never do again nowadays because ethics. They had people who were being intravenously nourished, and they said, what happens if we just remove all the potassium from their feed? What happens? What happens if we just remove all the sodium, potassium, nitrogen, phosphate? They did some cool stuff. And while they were doing this, they were monitoring 3 major body compartments: fat, muscle, and bone. And they actually found that when they removed all the potassium from the feed, they lost any capacity to form muscle tissue. And this makes a lot of sense, because you can't build something if you don't have all the ingredients. And we know that potassium is what we call an intracellular electrolyte. It's inside cells. It's a requirement for cells. And if you don't have enough of it, it makes sense, because you can't build a cell that doesn't contain potassium, right? So it makes sense that if you don't have enough potassium, you don't have any potassium coming in, you're not going to be building new tissue. And not only were the subjects in Louise's study in the low carb group having less potassium than the control group, they were having less potassium than recommended by the dietary guidelines. They were on a potassium deficient diet. So they didn't supplement with sodium in any meaningful way. They were deficient in potassium. They were incompletely keto adapted. And so is it any wonder? I mean, you can point at all the errors in this study. It's no wonder that they didn't find anything promising. And the kicker was when they reported the major finding was reduced exercise efficiency. And the data which they cited as supporting that was a study from 1920. And this study in 1920, they looked at people on a high-fat diet and had a look at their exercise efficiency, and they found that, or their efficiency, and they found that it was worse. Do you know how long this study in 1920 ran for?
No.
3 weeks.
Awesome. Okay, so
3 weeks, exactly the same. So clearly, so all that has been found is that if you are incompletely keto adapted with a deficient diet of sodium and potassium and probably some other things, and when I say probably some other things, I can give you a list of other things which were actually significantly impaired, including thiamine, riboflavin, niacin, vitamin C, folate, and iron. So this is not a restricted list at all. So you put somebody on a deficient diet, incomplete period of keto adaptation, you're not going to be as efficient in your exercise. Is that really a groundbreaking revelation? Did that really merit all the column inches that it got? No, that's bollocks.
Yeah, it is. That's absolute nonsense, isn't it?
And when we actually look at it, so we can compare it to actually like Volek study, so metabolic characteristics of keto-adapted ultra-endurance runners. So they are also elite athletes. They were on a diet for at least 9 months. So they were very well keto-adapted. They got them to run on a treadmill for 3 hours. And what did they find? Well, they found that the fat oxidation was clearly different. And the big argument about you can't exercise at intensity, well, they actually found that they were still burning a gram of fat a minute, exercising at 80% VO2 max. And 80% VO2 max is the intensity that an elite runner will run to win a marathon. So, I mean, this is not, this is actually pretty high levels of exercise intensity. And then they did the kicker. You would have heard that the reason low carb and ketogenic diets don't work is because they lead to glycogen depletion. So in this study, braver than me, every subject volunteered for 3 muscle biopsies.
Oh, no, thank you.
Before the run, immediately after the run, and after a couple hours.
Yep. Oh, that's going to be sore.
Do you know what the difference? Well, I've actually, I was doing a podcast with Zach and Sean the other day, and Zach, he was one of the subjects in that study, and he was saying it was pretty awful running, continue to run for 3 hours after you've just had your leg cut open. But anyway, I said, brave. Hey, but do you know what the differences in muscle glycogen was between the two groups?
Given my knowledge of exercise physiology, I was going to say 0. And the reason I was going to say 0 is because your resting glycogen level is determined by your training status and not by your diet. Well,
and not only was it your resting state level, but immediately after the exercise and 2 hours later. So they started with the same baseline, they declined by the same amount, and then they recovered by the same amount. And in that recovery phase, the high carb athletes, they got given high carb replacement shake. Do you know what the low carb athletes got? They got fat. Okay. So, this whole thing about, so if the theory of saying, the whole premise of a low carb diet being bad for you is because it leads to glycogen depletion, well, that's not right. And then we have to question, well, then can you, is your power necessarily affected? And there's this study, a McSweeney study, MCSWINEY, and that was published in 2018. And that was looking at people in a 12-week study, and they tested them with a 100-kilometre time trial, but they also did some power tests. And basically they found that the time trial performance, so the high carb diet, they improved their time trial by an average of 1.13. These minutes. The low carb diet, they improved by an average of 4.07 minutes. And then when they did the peak, the 6-second sprint peak power, the high carb diet had a slight reduction in their peak power. The low carb diet, they had an increase. And then what they call a critical power test, which is sort of simulates the end of a race where you maintain as much power as you can for 3 minutes, just like when you're trying to drop somebody when the finish line is in sight. Again, the high carb athletes had a drop in their critical power test. The low carb athletes had an increase. So the low carb athletes had basically a 3-minute advantage in terms of improvements in their overall time. And they had an increase in both 6-second power, like very explosive, and then the critical power test over 3 minutes. And this is entirely consistent with what we expect. And then we for the final, if I can coin a phrase, nail in the coffin of the supernova study, we can go back to have a look at what Finney found in 1980 with his study on getting obese subjects to lose weight and go on a treadmill. And they looked at their exercise efficiency, and they found that their exercise efficiency actually increased. And the way in which they did this was really interesting, because they got them to lose a bunch of weight over 6 weeks. And then they said, okay, you've lost weight. So now if we put you on a treadmill, it's not fair, because you're going to be more energy efficient. So we're going to get you to carry a weighted backpack. And there was no exercise intervention over the course of the study. It was purely dietary. And even though they were carrying a weighted backpack, they were using less oxygen, which I think is absolutely fascinating. So, you know, the whole notion that you can't exercise and win, you know, that it's detrimental for your performance is based on junk science.
Yep, absolutely agreed. So in summary, science, bitches, is what we're saying here. Dr. Paul Mason, thank you so much for your time today. It's been an absolute pleasure. I think we've put the world to rights, but I would like to have you back another time to talk about more and other things as well. But in the meantime, absolutely outstanding, and enjoyed it very much. Would you like to leave us with closing remarks?
I don't know, you sort of throw me a bit there, Bart. I'm very grateful for your kind words there. Look, it's been a blast. You're a smart guy. You're doing the right thing. If you want to find me, I'm on Twitter, Dr. Paul Mason. And if you're interested for Kiwi Cousins, I'm doing online consults now over video. So the link there is on my Twitter handle. But otherwise, look, just don't eat crap food. There's no obligate need for carbohydrates, and oils are no good, even including olive oil. Just eat real fats. If your fat is solid at room temperature, it's a healthy fat. Yep,
agreed on all counts. You're a gentleman and a scholar, Paul. Thank you so much. Thank you, everybody, for tuning in. Tune in next time for something completely different, but probably very similar. See you then.